I'd like to introduce Dr. Christopher Simutowe. Dr. Simutowe's journey in medicine began at the University of Zambia, where he earned a Bachelor of Science in Human Biology and later his Bachelor of Medicine in Surgery. He did his postgraduate work at the Royal College of Surgeons in Ireland, and he received the title of Fellow of the Royal College of Surgeons in Ireland. He is a Fellow of the Royal College of Surgeons in Edinburgh and the College of Surgeons of East Central and Southern Africa. Over the years, Dr. Simutowe has held significant positions, including serving as the Medical Superintendent of Kasama General Hospital and the Provincial Health Director of Northern Province in Zambia. His clinical expertise expands many things, including managing multiple trauma patients, general surgical conditions, orthopedic surgery, urology, obstetrics, and gynecology. That's a lot. Dr. Simutowe's commitment to education is evident through his past involvement in teaching at various institutions and his contributions to the College of Surgeons of Eastern, Central, and Southern Africa. He has played a pivotal role as an examiner, contributing to the University of Zambia and the School of Medicine for Copperbelt University. Currently, Dr. Simutowe serves as the consultant surgeon at Luanja Copper Mines in Zambia, where he manages a wide array of surgical conditions for mine employees and registered members. He has been providing bloodless medicine and surgery service since 1989, and it says he's close to retirement, and he's going to start a private practice providing bloodless medicine services. And welcome to Dr. Simutowe.
Thank you very much. I'm going to present bloodless surgery techniques in a low resource setting. The layout of the presentation is as follows. I'll present 2 case studies, clinical cases. Then after that, we'll discuss key components of successful bloodless surgery, focusing on good surgical training, adequate preoperative preparation, strategy for intraoperative management, and a detailed post-operative monitoring plan. Our first case. This is a gentleman, 40-year-old gentleman, who presented with abdominal pain, which was associated with episodes of diarrhea, but there was no vomiting. On examination, clinically, he was pale. The conjunctiva, the palm, the blood pressure was fairly okay, the pulse, a bit of a tachycardia. And on examination, when lying flat, you could see the fullness in the left hypochondrium. And on palpation, there was a definite palpable mass in the left hypochondrium extending up to the midline. The rest of the physical examination was normal. Okay. On the investigations done, the abdominal ultrasound confirmed the mass in the right hypochondrium, which is an enlarged spleen. The full blood count showed an HB of 8.1 grams per deciliter and white cell count of 2.3. The film content showed signs of iron deficiency anemia. Management of the patient. The patient presented with features of hypersplenism. This is a condition where the spleen gets very overactive and starts destroying blood, also the red blood cells. And after discussing with him, he was reluctant initially to undergo an operation. And we gave him time to think about it. And in the meantime, we just put him on oral ferrous sulfate and folic acid to build his blood. After 1 month, he came back. He was more confident. And this time he agreed for surgery. The pre-operative management that we did showed that the HB was 9.6, it had gone up. And the fact that he didn't want any blood. But at 9.6, we were comfortable to proceed with the operation. So we went ahead with a laparotomy to do a splenectomy. This involves using a long midline incision, making sure that we get all the bleeders. And then in the abdomen, the spleen was quite big. It's easier to remove a big spleen. We were able to get all the blood vessels quite well attached to the spleen. And the patient recovered well. Post-operatively, After a week, the hemoglobin had come down slightly to 9.2. And that is the spleen that we removed. It weighed 950 grams. The normal spleen is really about 30 to 50 grams. And those are the features which was clinically like a tropical splenomegaly. In the tropics, we do get a lot of parasitic infections and malarias. So usually we get a lot of spleens which are quite enlarged. The patient was seen back after 4 months and he was in good health, and his hemoglobin was 9.6 and platelet count was okay. He recently came back to see me just to bring another patient who was anemic. He's in good health. If we go back to the pillars of patient blood management, where initially we need to optimize the hematocrit, which we did on this patient. Initially it was low. We just put on oral hematinics, which helped to bring the blood high up 9.6. The second pillar, minimize blood loss. The surgery was quite good, meticulous, making sure that we actually didn't lose much blood, and he did very well. The same pillars of bloodless surgery, optimizing hematocrit, which we did, minimizing the blood loss, which we took meticulously during the operation as well, until we recovered quite well. Okay. The second case we had is a 36-year-old gentleman who was a driver. He was involved in a road traffic accident on 3rd September 2012. He was denied treatment at 2 hospitals because he refused to receive blood transfusion. So we received him at our hospital after a 1 week. The accident was on 3rd September. We received him on 9th at our hospital. He had sustained fractures of the bones of the right leg, upper leg, the thigh, and also the right lower leg, the tibia and the fibula. Okay. So these are the other findings. And the HB was 6.5 grams. Okay. The plan that we made for him was to raise the blood level, and we divide the operation in 2 parts. The first operation would be done on the lower leg, then the second operation to be done on the upper leg. And this was to reduce the blood loss if one was to do an operation in 1 day. So during the pre-operative period, we put him on skin traction, and he received iron sucrose, 5 mils in 100 mils of normal saline burette on alternated days. This is how I treat my anemic patients. And they also given erythropoietin, 4,000 international units intravenously daily. After almost a week of treatment, by 17th September, the hemoglobin has gone up to 9.7 grams. And at this level, the decision was made to proceed with the operation. So what we did was an open reduction and plating of the tibia and fibula. And during this operation, we put a tourniquet on the thigh to reduce the blood loss. He recovered quite well, and we continued monitoring him, and his hemoglobin was rising as we were operating on him. Just this one. So on 21st September, his hemoglobin had risen to 10.5. And on the 28th September, his hemoglobin had risen to 12.4. I'm sorry, I think maybe you can't see that from there. And hence, another decision was made to actually do a second operation, which was done on 3rd October. Okay. This was now an open reduction of plating of the right femur, the thigh. Okay. So the post-operative period of this one, the HB came down slightly to 10.3. It was closely monitored and finally discharged on 10th October, the same year. The condition is well, he's back driving around the long distances. Again, if we go back to patient blood management pillars, optimizing hematocrit, which we did, he came initially with HB of 6.5. We managed to raise it high up, and he was fit for surgery. During the operation, we managed to minimize the blood loss, and we supported his anemia. The same pillars of blood surgery, again, we optimize the hematocrit, minimize the blood loss, and optimize the oxygen concentration. The key components for success, I think in our area, one needs to have a very good surgical training, and one needs to have adequate pre-operative preparation, and one needs to develop a strategy for intraoperative management. And then we want to have also a detailed plan for post-operative care. In good surgical training, it's important that a health worker certified to carry out surgical operations is adequately trained and qualified. He should be competent. The essentials that he needs to have is he needs to have a good anatomy, knowledge of anatomy, a good physiology, and pathology. He must know the surgical operation techniques to be able to carry out operations. Okay. Patients should be adequately prepared. We need to really comprehensively prepare the patient. We should do all the necessary investigations and address the problems before operation. The emergency tools which you should always have available is tranexamic acid, vitamin K, IV fluid should always be there, a tourniquet when it's needed, and bandaging or packing, depending on the type of operation one is going to do. So in all elective cases, we need to treat issues like anemia with iron sucrose and erythropoietin. This is the standard I use. It's important to develop a strategy for intraoperative management. For every operation one is doing, we need to review the operation steps. It is very important. Okay? And then so that we need to anticipate the potential problems we might face while operating. And for every surgery, it is important to understand vascular anatomy. By knowing the vascular anatomy, you can avoid some of the bleeders that you can come across. And you will know if you come across a bleeding, where it's coming from, and how to stop the bleeding. It is very important to brief the theater team. As the operating surgeon, your assistant should know what you're going to do, should know your steps. The scrub nurse should know what you're going to do, should know the steps. The whole team in the operating theater, if they understand you and they know what you're going to do, they can assist you in the operations and things can work very well. The essentials during operations, that do IV lines, as I said, tranexamic acid is a key. And we need to make the first proper incision. All this with careful planning, one can do well, and usually patients can recover quite well. The post-operative period is equally critical. So we need to plan how to look after the patient very well. Close monitoring, the blood pressure, the pulse, the temperature, in case there's a bleeding that has occurred. So it is very important to closely monitor the patient. Vigilance for any potential complications that might come, we should always be alert. Okay. So in summary, again, just to emphasize the importance of training, one needs to have a solid foundation of surgical training, surgical practice. We are able to handle complex cases in a low-resource setting with good training, and the importance of understanding the human body, the intricacies, and also the surgical techniques. Under surgical techniques, I think even how to handle artery forceps, how to handle the sutures, how you make your knot, all these one needs to be knowledgeable to this, so that if you don't tie someone nicely, they start bleeding, postoperatively, those are complications that you have a good understanding of surgical techniques, you can actually do quite well. Preparation is key to reduce complications. Let's always conduct the necessary investigations and address arising issues which can come. And then intraoperatively, a clear strategy for smooth surgery is important. Still emphasizing vascular anatomy, you need to do this, you need to know this. If you're going to do a thyroidectomy, any laparotomy, it's important to know the vascular anatomy so that you can go to a good operation. Briefing the theater team. It's very important that as a team, they all understand what is happening, and then things will be fine. Let's have necessary equipment at hand, which is very important. Okay. So postoperatively, the close monitoring of patients are always very important. Okay. So in conclusion, it is possible to have a successful outcome of bloodless surgery in a low-resource setting. With good training, good strategy, it is possible to achieve quite good. I think that was my brief presentation. Thank you.
Thank you very much, Dr. Simutowe. We'll have some